Hi.
Hi, Praveen.
Good morning for you. Good
Nice
evening
to
for
see you.
us.
Yeah.
Good to see you. It gives me an immense pleasure to introduce Dr. Joe Carrillo. He's a senior pediatric intensive care physician, has been at Pittsburgh Children's Hospital for a long years, as long as I have known of him. He has been a key person in publishing 2002 neonatal and pediatric hemodynamic parameters guidelines. They have been revised several times, 2007, and then finally in 2017. And currently, he is on the task force of redefining pediatric sepsis, the revised pediatric sepsis guideline. Now, in all of this, he has had more than 340 publications in index journals. He is also involved with a precise trial on anakinra, as well as he's also involved with the GMCSF. So his talk today is going to be concentrated around ferritin, CRP, other inflammatory markers to really look into what is their impact on mortality, and also emphasize, is this an under-recognized thing in the PICU routine of the intensivist rounds? Dr. Carrillo.
Thank you, Praveen. Will you bring up the slides or should I share my screen?
I think you should.
Okay.
Yeah.
Can you see them?
Yeah, if you could do the slideshow. Yes.
Yep. Okay, great. So Dr. Bott asked me to put this slide first. That's me.
Yes.
I apologize that my camera's not working today. It may be to your benefit. We'll see. The title of this talk is I Got the Fever. And we're going to talk about using procalcitonin C-reactive protein and ferritin levels to guide therapy in pediatric sepsis. I think I am not going to give the wonderful talks that were given before. My talk is a bit more practical, I think, for you. So this is a child in our ICU who had respiratory Enterobacter pseudomonas infection, had C. diff infection, had peritoneal Enterobacter pseudomonas, a very prolonged course. You see the child had peritoneal drains. The child was treated with anakinra and with methylprednisone, and with a great deal of management of abscesses. You can see that each day we obtained a ferritin level, a procalcitonin level, a CRP level, and a white blood cell count. Now there are approved for you and available to you in your laboratory tests, 3 tests that we'll concentrate on today. First is procalcitonin. It's made by the Clara cells of the lung. And the higher the level, the more likely you are to have sepsis and more severe sepsis. C-reactive protein was the first pattern recognition receptor identified. It recognizes both the C polysaccharide on bacteria, but also phosphatidylcholine on your host cell. And so it will increase if you have any necrotic cells of your own making, or if you have bacteria. And then ferritin is released by macrophages, as is C-reactive protein. And it is released in 2 factors in response to iron, but also toll-like receptor 9 stimulation by DNA viruses, host mitochondrial DNA viruses, damage-associated molecular patterns, and actually we'll talk about in response to sequential viral and then bacterial infections. I've lost your picture. Can you still hear me?
Yes, we can hear you.
Okay. When ferritins are high, they can be related with iron overload. And patients who have iron overload, it will be related to a transferrin saturation greater than 45% or a total iron binding capacity greater than 40%. But otherwise, if ferritins are high, you can feel fairly confident it's a marker of macrophage activation.
As a blood pressure, who will increase in aliquots of 2 and will make sure that at each peak we give 10 to 15 breath cycles, and then at the end of 10 to 15 breath cycles we perform the.
I request all the participants to please mute yourselves. Thank you.
Okay. In clinical practice, pediatricians use procalcitonin to assess bacterial infection and sepsis risk. And today we'll discuss whether C-reactive protein and ferritin can be used to assess systemic inflammation risk in hospitalized children and to aid in assessing response to therapy. So here are the levels for procalcitonin. Less than 0.1, a bacterial infection is highly unlikely. And there's a strong recommendation against using antibiotics. From 0.1 to less than 0.25, bacterial infection is unlikely, and people still recommend against it, although it's not highly unlikely. But at 0.25 to 0.50, bacterial infection is likely and antibiotics are recommended. And if it's greater than 0.5, bacterial infection is very likely and strongly recommended. Now, when we think of the cytokine storm, we published about the cytokine storm in 1996 in sepsis. In this simple form, and you're at the bedside and you're trying to figure out if your patient might have a cytokine storm, it's fever. So that's why the title of this talk is I Got the Fever, which is also the name of a popular song as well. So fever is generated by the hypothalamus thermoregulatory center, and specifically in response to interleukin-1 beta. Interleukin-1 beta is released by white cells. And then interleukin-1 beta can affect endothelial cells to make IL-6, and then that in turn can cause the liver to make C-reactive protein. IL-1 beta can also affect the bone marrow directly or through IL-6, and that affects platelet counts. If you inject endotoxin into a volunteer, these markers have a certain time pattern. You can see that the first marker to go up is IL-6. The second marker to go up is procalcitonin, and procalcitonin goes up fairly high. So you can see that if you have a patient who's coming in the first hours of bacterial sepsis, they'll be below levels that are recommended for treating bacterial infection. But if it's after 3 hours, this patient will reach a procalcitonin level that's above the recommended levels. Now, C-reactive protein has a greater delay. So C-reactive protein goes out 6 hours, and when you're looking at C-reactive proteins greater than 1 as a marker, out 12 hours. So that's why it's recommended that you use procalcitonin. Now, if you have IL-6, IL-6 is fine too. But what you'll notice about IL-6 is even in the face of a bacterial infection, or in this case, bacterial antigen, it will return to normal by 24 hours, whereas procalcitonin will remain elevated all the way out to 72 hours. So that's why it's recommended in general terms to use procalcitonin as the best marker, because it goes up early and stays elevated. And then the next marker recommended would be IL-6, but you are unlikely to have that at the bedside. And then the next biomarker would be C-reactive protein, which basically you have to wait for 12 hours before you can expect it to go over the positive diagnostic level. This slide by Dr. Slats, Tenover, Van der Verdonk, and Nadia from Holland shows the evolution or the more recent thought process on how you can use biomarkers at the bedside to distinguish in part between bacterial infection and viral infection. So the bacterial infections we talked about increases IL-1, and that leads to IL-6, and IL-6 leads to CRP. So you can look at procalcitonin or CRP levels. But viral infections, as was pointed out earlier, actually lead to an increase in IL-18 production. And that, in response, increases ferritin. So you can get an indication of a viral infection according to ferritin levels. On the left, you can see that you can actually put together a figure with CRP on the y-axis and ferritin on the x-axis, and it's demonstrated nicely. So you can see the CRP is quite low, and the ferritin goes up from normal to hepatitis C virus, Epstein-Barr virus, HIV virus, and dengue virus. And then when you're looking at bacterial infections, you can see that the ferritins are quite low, but the CRP is higher with bacterial meningitis, sepsis, salmonella enteritis. And pediatric sepsis is rather interesting, just to note, because children, which are the patients I take care of and are taken care of at Rainbow Children's, actually have a bit of a higher ferritin level and a higher C-reactive protein, which is really the topic of this talk. Now, unlike what we heard earlier, where there was a lot of talking about ferritin being related to viral infection and T-cell activation, most of the increase in ferritin that we see in sepsis is actually related to red blood cells. So ferritin will go up because you have been given blood transfusions, or more commonly in our patients, if you have an endotheliopathy, your red blood cells lyse, you may or may not see schistocytes. Free hemoglobin goes up, it attaches to the hemoglobin haptoglobin complex. And this in turn is broken down in the macrophage and results in a release of ferritin. Now, if you're trying to figure out if this process is at play, if you send off a blood gas and you look for carbon monoxide levels, you'll see these patients will have high carbon monoxide levels. And so in sepsis, we commonly see, because of endotheliopathy, low-grade hemolysis, an increased carbon monoxide level, and an increase in serum ferritin. But when you look translationally as well as transcriptionally at what controls ferritin, it's the iron through the iron responsive element, which is A, and B, but it also interacts with TNF alpha and IL-1 alpha. So if TNF and IL-1 are increased, this increases the transcription of iron. And then if you have free iron, this increases the translation of iron. So commonly in sepsis and in the ICUs and in the hospitals with children, you're seeing a combination of the effect of inflammation, but also free hemoglobin. And the type of hemoglobin that is made can either be what's called, the type of ferritin that is made can also be called type 1 or type 2. Now, when you look at this model of inflammation, you can see on the left upper hand corner that hemoglobin, haptoglobin, SCD163 can increase free iron to increase ferritin. And when you look at the upper right-hand corner, you can see that viruses, as well as damage-associated molecular proteins and host DNA, can all stimulate toll-like receptor 9 and activate the inflammasome. The inflammasome can increase interleukin-1 as well as IL-18. IL-18 can stimulate interferon gamma. Interferon gamma, as well as IL-1, can directly increase ferritin levels. Now, what's interesting about ferritin is that ferritin itself will upregulate it in a promiscuous fashion, all toll-like receptors. So there's actually a positive feedback loop that occurs. And in blue, you can see various therapies you can use to block these. So if you have free hemoglobin, you can use plasma exchange therapy. You can also use pentoxyphylline, which will reduce hemolysis and also control TNF levels. For viruses, you can block the viruses with IVIG. For inflammasome activation, you can use glyburide or other small molecules. For IL-18 binding protein. For interferon gamma, you can use anti-interferon gamma. You can use, for lymphocytes, you can use anti-thymocyte globulin, and you heard earlier about etoposide. But the key aspect of things is that ferritin itself actually induces in hyperferritinemic sepsis and MODS both immune suppression and inflammation. So you get the seesaw that was previously reported in the prior lecture of both an immune suppression phenotype and also a hyperinflammation phenotype. Now, we kind of finally understand from this animal model why some patients with sepsis develop hyperferritinemia and hemophagocytosis, and other patients with sepsis do not. And this is amongst the patients who do not have genetic abnormalities. These are normal mice. And in this experiment at the Yale Immunobiology Laboratory at the Howard Hughes Institute, they subjected the mice to different sequences of antigens, bacterial then viral, bacterial then bacterial, bacterial then viral, and then viral and bacterial. And of these, what they found was a distinct pattern of cytokine activation and hemophagocytosis in patients who in mice who were first exposed to viruses and then bacteria. When we look at children in the ICU, co-infection, virus and bacteria infections together are what's related with worse outcomes in pediatric sepsis. You can see in panel A that ferritin levels go up dramatically in the mice who are virally primed and then bacterially infected. And this is true with antigens as well as live cultures compared to all the other sequences. These patients have high triglycerides. They develop high liver injury, low white count in hemoglobin or cytopenias and platelets, a high SCD25, and a high hemophagocytosis. And from Dr. Hendler's talk, where he was talking about this as being the HLH-MAS phenotype, he concentrated beautifully on the concept that this is driven by T cells and interferon gamma. But in sepsis, it's the opposite. What it's driven by is by macrophages. And so these investigators, it's macrophage activation. So these investigators, when they gave 2-deoxyglucose, they were able to resolve this phenotype and save the mice. But when they gave interferon gamma antagonists or use interferon gamma knockouts, or they did T cell knockouts, they didn't help these mice. So this model of sequential viral then bacterial infection is not interferon gamma driven, it's not T cell driven, and instead it's macrophage activation driven. And the 2-deoxyglucose, what it does is prevent glycolysis in the macrophages, because the only way that you can have macrophage activation syndrome in sepsis is for the macrophages to metabolically reprogram from oxidative metabolism to glycolytic metabolism. Now, very important thing as to why we have to be careful with our words of SHLH versus infection-associated HLH versus hyperferritinemic sepsis is that when they treated the other mice who had bacterial, viral, or viral bacteria with 2-deoxyglucose, they actually killed the mice. So there are specific phenotypes that need to be treated differently. You need your macrophage function when it's bacterial followed by bacterial. You need your macrophage function when it's viral then viral. You need your macrophage function when it's bacterial and viral. But when it's viral programming and then bacterial, the macrophage activation itself is deleterious. In this paper, we looked at children with sepsis, and we show that as your maximum ferritin level goes up, the number of circulating DNA viruses goes up. And so higher ferritin levels, specifically over 1,000, are associated with an increase in reactivation of DNA viruses, including EBV, CMV, HSV1, adenovirus, parvovirus, and BK virus. And to some degree, what you're seeing is the combination of DNA viremia driving the ferritin process. Now, the good news is that there is a way to treat this in animal modeling. If you give an animal a CpG as your viral antigen, and then give endotoxin for gram-negative, or you give lipoteichoic acid for gram-positive, the macrophages and dendritic cells, again, macrophage-driven, they release inflammatory cytokines, IL-1 beta, and this stimulates with TNF cell death in the hepatocyte. The hepatocyte will make interleukin-1 receptor antagonist protein, which is anakinra, to block this process. The type 1 interferon gamma, or type 1 interferons, will also block this process and prevent liver injury. So, interleukin-1 receptor antagonist protein and interferon, type 1 interferons, will prevent liver injury and inflammation with this co-infection mechanism in sepsis. And that's shown here. You can see they give the CpG plus LTA, which is virus plus lipoteichoic acid. Then they give PEG interferon alpha, and they can improve survival in panel B. I'm sorry, in panel A. And then you can see in panel B, in this model, they pre-treat with anakinra, and they can then give the virus and the LTA, and this time endotoxin, and they can protect again. So you can have protection in animals. And in this study in 2015 with Dr. Bidashikuri and Dr. Andy Krohn, we contacted Dr. Steve Opel, who had done this pivotal trial looking at anakinra back in the 1990s. And of note, almost all the DMARDs, or the biologics that are used in rheumatology, actually were first developed in sepsis, and anakinra was not different. The reason that these anti-inflammatories went from sepsis to rheumatology is they're very effective against pro-inflammatory conditions such as arthritis, but you still have to kill infection. So in this major trial with interleukin-1 receptor antagonist protein, there was no difference in outcome from adults with septic shock. But Dr. Shikuri, after analyzing the data from Dr. Ravelli's consensus criteria for rheumatologic macrophage activation syndrome, found that if you had combined hepatobiliary dysfunction and disseminated intravascular coagulation, the likelihood of meeting Ravelli criteria was 81-fold higher. So we just applied these criteria in a post hoc manner to this randomized controlled trial. And what we found was when you took patients who did not have hepatobiliary dysfunction or DIC, and you treated them with anakinra or placebo, there was no difference in outcome. The survival probability was approximately 70%. Now, when you looked at the survival probability of patients who had hepatobiliary dysfunction, DIC, which represented 6% of septic shock patients, you saw in the dotted, bolded lower line, a survival of only 35%. And when those patients were treated with anakinra rather than placebo, you could see that you could restore the survival of those patients back to the same level as patients who didn't have macrophage activation syndrome. So unlike the animal model from the Yale University Immunobiology Lab at Howard Hughes Institute, which showed that deoxyglucose or 2-deoxyglucose to inhibit macrophage function killed the animals who did not have the sequential exposure to virus and then bacteria, anakinra did not kill the patients who did not have hepatobiliary dysfunction, DIC. So it was safe even in the patients without it. But like 2-deoxyglucose, using that as a macrophage inhibitor, using anakinra as a macrophage inhibitor in this subset of populations improved their survival. And so this was really our first kind of proof of concept that if you go after the macrophage in sepsis-associated or septic shock associated macrophage activation syndrome, defined by hepatobiliary dysfunction and DIC, you can improve outcomes in this group of patients with a very high severity risk. Now, you could actually define these patients based on ferritin levels as well. You saw earlier the varied definitions using ferritin. One was 2,000. And here you can see that when we looked at the whole population in this post hoc analysis, a ferritin greater than 2,000 had 20% less survival than a ferritin that was less than 2,000 in these adult septic shock patients. And when you look at these patients who had a ferritin over 2,000 and then broke down the treatment of anakinra versus placebo, you can see that this mortality risk was completely reversed. That is to say that anakinra group's survival was the same as though you didn't have a ferritin greater than 2,000. Now, coming back to Rainbow Children's then, with all that background about CRP and ferritin and procalcitonin, the question is, can I use a contingency table of C-reactive protein and ferritin to identify systemic inflammation mortality risk in hospitalized children, or a cytokine release syndrome that is related to mortality that perhaps I want to intervene in? And this study, which we published in 2019, is from Children's Hospital of Pittsburgh. We first looked at all the patients who had received CRPs and ferritins in our hospital. And then we did a receiver operated characteristics curve with a Unins index. And you can see that the cutoffs that were best at predicting mortality were a ferritin level greater than 373.7, or a C-reactive protein level greater than 7.1. And notice that we use milligrams per deciliter in our hospital for CRP. Now, if you set up a 2x2 table and you call low systemic inflammation risk patients who had a CRP below this threshold, below 7, and a ferritin below this threshold, below 373, you can see these low risk patients. None of the patients died in the hospital. Only 1 of 100 had died at a year, and their organ dysfunction score, their PUOD score, was relatively low at 6. Now, the next thing we looked at is, what if only one of these biomarkers of cytokine storm are up, and meaning CRP's up, but not ferritin, or ferritin's up and not CRP? And you can see that if your CRP was up, but ferritin was not, that your mortality in the hospital was close to 6%, remained 6% a year, and you had developed higher organ failure. Now, if your ferritin alone was up, you saw a mortality rate of 7% at 90 days and a year. So very similar, but clearly higher than 0% when you were below both thresholds. And if you were above both thresholds, your ferritin was over 373 and your CRP was over 7.1, your mortality in the hospital was 21%. And importantly, it went up to 30% at 90 days in a year. And your organ dysfunction score went up to 12, showing you quite nicely that you could, at the bedside, gauge cytokine releasing syndrome or storm and its severity related to mortality risk with 2 very simple tests. In hospitalized patients, not just ICU patients. This is a plot that is called a bag plot. And here, this gives you the advantage of both seeing the CRP and ferritin together in an individual patient. The dark blue represents the 50% with the lowest inflammation. the light blue with more inflammation. Now, the center where you see a gold trapezoid, that is the Tukey median. That is the patient who has the median amount of inflammation, combined CRP and ferritin. And when you look to the right upper quadrant of this bag plot, you can see circles. Each of the circles were death, and you can see quite nicely that all but one of the deaths occurred in the patients who had the highest ferritin and CRP inflammation together, consistent with the 2x2 table. And one of the deaths was associated with a patient who had higher CRP, but not ferritin. When you look at the Seattle Children's, just looking at ferritin alone, they show that the risk for requiring ICU care in the hospital or death goes up as you go up above 1,000 to 3,000 and then 3,000. And in fact, using Cox proportional hazards, it's a stepwise risk at 1,000 on up. And still not, this is still well below the 10,000 that people are using for MAS HLH. Now, we do the same thing with children with severe sepsis in the ICU. In this paper, we show that the initial ferritin and the initial CRP are actually more predictive of outcome than the PRISM score, which is the pediatric risk of mortality score that's used. Here, the area under the curve for the PRISM score is 0.67, for CRP it was 0.77, and for ferritin, 0.88. And when we do the 2x2 plot using the same technique as we did in the hospital, we see a very similar finding. Now, the cutoffs are different. The cutoffs in our ICU, rather than being 7 as it is in the hospital for CRP, it was 4. And for ferritin, rather than being 378, it was 2,000. You can see in our ICU that if your CRP and ferritin are below the threshold, there was 0% mortality. We had no patients who had a ferritin over 2,000 and a CRP under 4. But amongst those who had a CRP over 4 and a ferritin less than 2,000, our mortality was 5%. And then this mortality went up to 46% when both CRP and ferritin were elevated. And when we took the patients who had elevated CRP and ferritin, if during their course in the PICU, their CRP and ferritin levels returned to the low inflammation box, they too had 0% mortality, and the mortality of the other boxes went up to 35%. Again, suggesting that if you can get inflammation down, your survival is much better in sepsis. Here's an individual patient. You have ferritin and ex vivo TNF alpha on the left y-axis and CRP on the right axis. This patient had a high C-reactive protein of approximately 30, but a normal ferritin of only 300. As the patient received antibiotics and cleared the infection, the patient's C-reactive protein comes down, the ferritin number goes up. The ex vivo TNF response, which is a response of blood to endotoxin in terms of TNF production as a marker of immune function, goes up, and the patient resolves bacterial pneumonia and septic shock. This patient starts with an elevated CRP and ferritin. The CRP was 23, and the ferritin was 3,500. The child had immunoparalysis. It was unable to fight infection based on our ex vivo TNF response to endotoxin. This was a transplant patient. Simply by tapering the immune suppression so that the immune system could recover and using appropriate antibiotics, we see the C-reactive protein and the ferritin normalize as we see the ex vivo TNF response in triangles increasing. There was a secondary infection at 23 days, which is where you see the bump in C-reactive protein again, but that was not viral and then bacterial. So you just saw a bump in C-reactive protein, but not ferritin. And that resolved with new antibiotics, and the child lived. In this individual patient who started off with no immune system, the ex vivo TNF response in triangles is actually along the 0 line, had a high C-reactive protein of 28 and a ferritin of 3,600. And you see over the 16 days as immune suppression was not dropped, that the immune depression continues throughout, and you see the CRP and the ferritin continue to rise until death. In this top panel, you see a child who came in with EBV, associated hyperferritinemic multi-organ dysfunction syndrome, which is indistinguishable really from the infection HLH, infection-associated HLH of EBV. You can see the ferritin levels on the y-axis and the hospital day. You can see that we started anakinra. The ferritin levels came from 1,800 down to 500. The anakinra was discontinued. The ferritin went back up to 2,000. The anakinra was continued again down to 500. This patient looked very much like a rheumatologic picture with serositis. We actually had to discharge her on anakinra, and she was followed for a year at the NIH. They never could understand why she had this syndrome, but it took them an entire year to wean her off anakinra. This was, however, virally induced. Below this is a patient who was 3-year-old who had adenovirus induced hyperferritinemic multiple organ failure syndrome. This was during the adenovirus 17 outbreak. On the y-axis, on the left, you see ferritin. On the right, you see adenovirus levels, and you see hospital days. This patient was required extracorporeal membrane oxygen support. You can see we started anakinra, and there was no drop in the adenovirus levels, PCR levels, but there was a minimal effect in ferritin. It wasn't until we started cidofovir on day 8 to treat the adenovirus that we saw the drop in adenoviral PCR, as well as the drop in ferritin levels. And then you see a spike in the ferritin levels, but not in the adenovirus PCR. That's because there was a perforation of the heart with a lot of blood transfusion on ECMO circuit. That blood increases the ferritin levels. We perform plasma exchange to remove the free hemoglobin, and you see the ferritin come down again. And then you see over time that the adenovirus DNA PCR titer normalized, as did the ferritin. So treatment not only of inflammation with anakinra, but also treatment of the viral infection. And so this brings us back to our initial patient, and you can see, I'm not going to take you through each of these factors, but you can see that by looking at CRP and ferritin as markers of your cytokine storm, IL-1, IL-6, bacterial related, and then viral or free hemoglobin related with ferritin, and then responding appropriately, you can control inflammation. And then looking at procalcitonin, you can use that as a biomarker for good source control. Remember, you've had 2 other beautiful talks, one on ferritin and one on COVID-19. But remember, there are other syndromes that are related to free hemoglobin, such as Ebola hemorrhagic fever, where ferritin levels, again, are related to sepsis, but also free hemoglobin. Dengue, which you had a very beautiful talk on, and COVID-19, which you had a beautiful talk on as well. In all cases, remember to look at procalcitonin levels, and if they're high, you need to really consider antibiotics, although clearly it may not be a live bacteria because it could be just endotoxin leaking, but we really don't want to take the chance when we have critically ill patients. So if your procalcitonin is high, bacterial or fungal infection, treat with antibiotics and antifungals. If your ferritin's high, see if it's iron overload and consider treating with desfluranox. If it's not iron overload, it's macrophage activation, treat with methylprednisone and IVIG. And if you can look at PCRs, you can use more specific treatments for virals. And if you have high C-reactive protein, think heavily about tissue necrosis, bacterial infection, or lymphoma, because the B cells from lymphoma stimulate IL-6 production and C-reactive protein production as well. Your ultimate goal in managing cytokine releasing syndrome using this CRP and ferritin contingency table is to have your patients go from high risk to low risk, intermediate risk to low risk, intermediate risk to low risk. Thank you very much.
Thank you, Joe, for giving an excellent talk. Basically, since you have emphasized so much on ferritin and C-reactive protein and the values, and I've shown that the mortality changes. Does that also apply to viral sepsis, or just this is a combination of viral and bacterial sepsis in children?
It also applies to viral sepsis.
Yes.
So,
okay.
So
okay.
going back to this, can you see my slides?
Yes. Yes.
Yeah. So these patients here had only viral sepsis.
Right.
The patient at the top had EBV. The patient below had adenovirus.
Adenovirus. Right.
Their procalcitonins were normal. They didn't have bacterial infections.
Right.
This patient here had bacterial and viral infection.
Right.
This patient only had a bacterial infection. You see the ferritins weren't high.
Right.
So it applies to all patients. And why might that be? Well, when you look at SARS-CoV-2, it's a viral infection. 71% of MIS-C patients have procalcitonins of 12 or higher.
True.
You cannot distinguish whether that's endotoxin leaking from the gut or that's live bacteria. And in the paper by Texas Children's Hospital, they had 100% survival in their MIS-C patients, despite 2 needing an Impella and 2 needing ECMO. And over 70% of their patients were being treated for bacterial infection. So it's not only live bacteria infections. Let me show you this again. When you look at this effect can be seen if you use the antigen of the bacteria or live bacteria. This effect can be seen if you use viruses taken directly off of tissue culture, or you just use the mimickers, like in this case, IC, which is a mimicker of RNA virus like COVID. So
yeah,
what it does, the CRP and ferritin, quite nicely, is if your procalcitonin is normal, you don't need to treat with antibiotics. But if your ferritin's high, you have to say, okay, what virus does this patient have?
Right.
And
Right.
does the patient have free hemoglobin?
Now, one question that's been brought out by Dr. Deepika, can we have high PCT even in CRS without bacterial or fungal infections like we have in COVID?
The answer is, again, the question is live or dead. So procalcitonin tells you that you have high circulating levels of live bacteria or dead bacteria.
And then what about the SJIA and MAS,
If procalcitonin is elevated, it means you either have live bacteria, at a high level, like it is with SARS-CoV-2 at say 12 in ICU patients with MIS-C, or with COVID-19 patients, adult patients. When you look at deaths in adult patients, they're all almost always from bacterial and fungal infection, not from the virus alone.
Right.
And so if you see a high procalcitonin, that tells you have live or dead bacteria. If you decide that it's dead bacteria, that's fine. But we treat it as though it's live bacteria. And what we see, which I didn't show you, but other papers that we published, is that Procalcitonin going up shows that you're not killing the bacteria and you die. So if you're
Right.
a sepsis patient and the procalcitonin continues to go up, your patient dies. If you treat the bacteria or remove the nidus, your procalcitonin goes down, your patient lives. So procalcitonin is really what we have that's best. Septicite is a new test, but it's only approved for adults. So right now we just have procalcitonin as the best.
Okay. Well, thank you, Joe, for that lucid talk. And I'm sure there are going to be